Next speaker tonight, I'm delighted to introduce Dr. Shams. Dr. Shams Abdelraheem, he's a critical care consultant in Manchester University Hospitals, and he is the ventilation lead in Manchester Care Organization. Dr. Shams is being graduated from Cairo University, and he has got his master's in critical care medicine. He has got also a European Diploma of Intensive Care Medicine, MRCB. He completed his training between Egypt and UK. And Dr. Shams is currently a critical care consultant in Manchester. He has a special interest in the ventilation and the medical education. It is my pleasure to introduce Dr. Shams tonight. He's going to talk about analgesia and sedation in ARDS. Dr. Shams.
Thank you, Dr. Tharwat. It's a pleasure to me to be with this stars of intensive care and anesthesia. And I'm very pleased to be among you tonight. Very really surprised by the number of participants, 153 until this moment. So hopefully for the next half an hour, we'll be giving some information about sedation and analgesia in ARDS. So let's share my screen. Before I start, can everyone hear me clearly? Is there any interruption in the sound?
Yeah, we can hear you, Dr. Shams.
Brilliant. Thank you very much. So first of all, I work for Manchester University Hospitals and have no conflict of interest talking about sedation and analgesia. And before I start, if I ask all participants, please scan this barcode with your mobile phone. You can go to a questionnaire. It's a very quick questionnaire about sedation and analgesia practice in your unit. It can take about 1 minute. You can do this while we're talking about analgesia and sedation. I will keep the barcode all the time during the presentation, but please, 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 please do participate in this questionnaire. It will be helpful to all of us. So let's start quickly. Introduction about the analgesia and sedation in the ICU. Many patients in the ICU require ventilation. Some of them will be post-operative or hospital-acquired pneumonia, drug overdose. So for various reasons, we need ventilation in the ICU. There's a common approach to the ICU ventilation, and we can summarize this in analgesia sedation. It's not actually sedation only. It includes the analgesia as well. The analgesia sedation approach for the common ICU ventilated patients requires less sedation to be given to the patient and more focus on analgesia. And the reason for that is to keep the patient more awake, more alert, and at the same time pain-free. While achieving this, we can reduce the delirium, we can prevent the delirium, and we promote early rehabilitation and liberation from ventilation in ICU. And there is good evidence that interruption of sedation and keep it to the minimal will lead to early extubation and will promote physiotherapy, rehabilitation, and then eventually discharge from the ICU. However, this approach is not necessarily practical in ARDS patients. What we have noticed and we learned about from the 2 days of ARDS from our brilliant panel is that some of our ARDS patients will require certain interventions like protective lung ventilation. So we need to control the ventilation completely. Some of our patients will require proning or being on the ECMO. So for various reasons, the light sedation and analgesia sedation is not necessarily the most practical approach for sedation and analgesia in ARDS. So on one side is the answer simply will be deep sedation. Do we have to put everyone on deep sedation when we ventilate them for ARDS? We'll go through all the possible approaches to ARDS sedation and analgesia. However, deep sedation has also some side effects, which is obviously the opposite of the analgesic sedation approach. Deep sedation doesn't promote wakefulness. It has more evidence of delirium. It delays rehabilitation and definitely delays liberation from ventilation and ICU. So we need to reach the balance of having good ARDS management from one side and prevention of the side effects of the sedation and analgesia. At the same time, we know some of our patients will require neuromuscular blockers, and this is a completely different story. When we start someone on muscle relaxant, that's a different story. And I appreciate that last time, the day one, we talked about the muscle relaxation, but I will talk today about the muscle relaxation, sedation and analgesia in the context of muscle relaxation and neuromuscular blockers. So the principles when using neuromuscular blockers, this is one category of the patients, and we know the indications from neuromuscular blockers now. There's good evidence for the use of neuromuscular blockers in the ARDS, especially the severe forms when the PF ratio is less than 150, and we're just seeing the ladder of escalation of the care of the ARDS patients. So when we use neuromuscular blockers, the patient will lose completely the power to move. However, that doesn't mean that they are not able to be listening to us or aware of what's happening and aware of the surroundings. And one of the most important issues about neuromuscular blockers is awareness during muscle relaxation or during neuromuscular blockers. And certainly it is associated with post-traumatic stress disorder. I remember myself, one of the patients that we intubated. Intubation was brilliant, nothing happened during intubation, but however, the patient was being transferred to another hospital, and during the transfer, the level of sedation wasn't deep enough, and the patient was started to be awake, rousable. However, she was completely paralyzed, and the end result of that she suffered from PTSD. It doesn't happen that often with us in the ICU because most of our patients are deeply sedated. But it can happen when we give short or rapid analgesia or sedation for induction of anesthesia, for example. And I'm sure my anesthetic colleagues can talk about it more and better than me. But the bottom line is that using the neuromuscular blocker means that we have to make sure that the depth of analgesia and sedation is adequate. So for that reason, having the patient on light sedation might not be ideal, and we need to have a different approach for sedation and analgesia. Well, the first step when we have severe ARDS and we decide to put the patient on neuromuscular blockers, first we need to make sure that there is effective analgesia. And when we talk about an effective analgesia, we have different options, but most probably that will include opioids. Whether that is morphine, fentanyl, alfentanil, remifentanil, whatever the type that we use of the opioids, there are different types. We'll talk about them briefly later on, but we need to make sure that there is effective analgesia. And having effective analgesia in itself is tricky because if someone is awake having some pain, you can ask them, do you have any pain? And they can say, yes, it's a pain score of 5. So simply they can tell you if they have pain score or not. You can always use the facial expressions to assess the pain severity. But sometimes when our patients are, well, most of the times when our patients are sedated or being ventilated, they cannot tell you what level of pain did they have. So decision making about effective analgesia can be tricky. You can use the vital data, but again, there is no evidence about it. So if the patient is tachycardic, hypertensive, it may indicate that they have some pain that's not well controlled. And when we're talking about ARDS, it's not necessarily in the context of COVID-19 or influenza or respiratory failure because of respiratory pathology. It can be secondary to pancreatitis. It can be secondary to any other pathology. So it's not necessary that the patient doesn't have any other source of pain. They might have post-operative pain as well, and they have ARDS. As I said, effective analgesia is a tricky step in the management of, in the first step of management of sedation and analgesia. Heart rate variability is another tool that we can use to assess the effectiveness of analgesia. But again, the evidence for heart rate variability is not strong. There are also some machines or devices that can measure the heart rate variability and compare it to the depth of analgesia and give you some sort of index. And that index can be used to decide whether the analgesia is effective or not. And again, this will take us to the point where we are not giving enough analgesia versus we're giving too much analgesia. With too much drugs comes the side effects, and with too little drugs comes the ineffective ventilation or ineffective respiratory control. And this is one of the important points about analgesia, especially opioid analgesia. They affect the respiratory center, and if you increase the analgesia to a certain degree to be effective, you may take away the respiratory drive and then make sure the patient will be better ventilated completely. Having said that, the next step after having effective analgesia will definitely be deep sedation. So if I say there is an approach for starting sedation and analgesia for neuromuscular blocker, I'd rather start with good analgesia first, and then we'll go for the deep sedation and amnesia. And the reason why for deep sedation and amnesia is that I want to make sure that the patient is not aware during neuromuscular blockers. Commonly, the agents that we can use for deep sedation and amnesia will be propofol or midazolam. But whatever the type of sedation, deep sedation that you use, we need to make sure before starting, and again, I'll say it again, before starting neuromuscular blocker, that the patient is adequately analgesed and sedated before starting neuromuscular blockers. And it can happen in the context of an induction and intubation, that we give the sedative and then we run the infusion straight away, and we run the muscle relaxant straight away. And this is not the ideal protocol. It's not necessarily the ideal approach to control the sedation analgesia. So let's say if we're starting induction, give the induction, give adequate analgesia and sedation for continuous period of time before you commence the continuous infusion of the neuromuscular blocker, or whatever that's intermittent or continuous infusion. But try first to make sure that you have good analgesia and sedation. As I said, commonly it's a propofol and benzodiazepines, and this is the first step in the management. Later on, after induction of analgesia and sedation, and then maintaining with neuromuscular blocker, we need to make sure that there is adequate sedation and analgesia being monitored, and whether that will be monitored twice daily or once daily. So you may interrupt the neuromuscular blocker on daily basis, and make sure that once the patient is off neuromuscular blocker, that the background of sedation and analgesia are adequate. There are some devices like this monitoring that can monitor the depth of analgesia, the depth of sedation, sorry. But again, there is no strong evidence to support the use of the BESS monitoring. And while we're using the neuromuscular blocker, it's a good idea to monitor the depth of relaxation. I'm not going into details of this because that was discussed on day one. But the next step will be, if someone is not on neuromuscular blocker, someone is not muscle relaxed, what will be the approach for the sedation and analgesia. In this case, there will be some comparison to the normal ICU patients on conventional ventilation, out of which the targets will be comfort and safety. So we need to make sure first that the patients are safe with sedation and analgesia. While they are ventilated, sometimes we need to do some life-saving interventions. So sometimes we need to put them completely to sleep, to put into central line or arterial line, or to put them on ECMO. So these life-saving interventions need to be done in a safe way, and sedation and analgesia will facilitate these life-saving interventions. To some extent, we still need to maintain the patient interaction with the staff, with the doctors, with the nurses, and again, we need to promote early recovery when possible. And these are the targets rather than having a single protocol. What we should think about when we decide about what sort of sedation, what sort of analgesia we need to use, these are the principles that we need to be focused on while we're giving the patient our treatment. So similar to what we said about non-ARDS patients, if someone is having lung protective ventilation without neuromuscular blockers, the priority will be for adequate analgesia and maybe short-acting sedation. So the first step will give a short-acting sedation as in propofol or other drugs like dexamethasone. So these will be short-acting, short onset and short offset. Once you stop them in 15 minutes, you can have the patient back away. Intermittently, especially with the severity of ARDS, we may need to go for short interval of moderate sedation. And when we say light sedation, moderate sedation, commonly we talk about RASS score. So RASS score between -1, -2 is light sedation, -2, so -2, -3 is moderate, and more than -3 is deep sedation. So we try to go for short intervals of moderate sedation in between. Whether we can achieve that by giving the patient boluses of sedation, or whether that is possible by continuous infusion, it may be necessary to go for short intervals of moderate sedation, especially when we need to control more the patient ventilation. When we go to that level of sedation and analgesia, we need to go for monitoring, and monitoring can be done on daily basis twice. One of the way of doing this is prescribing your sedation target. So the morning round, you ask for sedation score of -2, RASS score of -2 or -1, whatever your sedation score, you ask for it, document that in your notes, and then the nurse will be able to titrate the sedation up and down to reach that score. This is really a common problem when so sometimes we ask for sedation halt completely, and then once you stop the sedation and come back, you leave the patient for 5 minutes and you come back and see the patient is deeply sedated again. And it depends on the nursing staff that you have, whether they will be able to manage the patient safely or not, or how confident and experienced they are in managing the patient. So some of the common problems that once the patient starts to be more awake, more alert, and coughing and gagging in the tube, the nurses will be very cautious about this, and they start putting the sedation back on again. And it depends on the practice in different units, whether the nurses have the liberty of giving sedation, giving medication, bolusing this, or the unit is completely doctors led. So every single decision has to be made by the doctors. Depends on the variation. For example, in our hospital, Manchester University, the nurses can go up and back on down on the sedation. It depends on the patient condition and variation that they can witness throughout the day. Nevertheless, we always ask for a sedation, certain sedation score to be in place And then if we, at any point, we decide to lighten the patient, we need to make sure that there are safe measures on the background in case the patient becomes very agitated or tube intolerant. Occasionally, we will go for a deeper sedation, whether that will be for the transfer or to increase the control of breathing. And again, this takes us to the analgesia. When you increase the depth of analgesia, you may take away the respiratory drive of the patient, and then eventually you can have good control of ventilation without the need to go for deep sedation. So deep sedation in the context of ARDS, lung protective ventilation, is not necessarily needed every single time, but you may go up to this level if control of ventilation is not achieved with adequate analgesia in the first place. So this is one of the protocols that was suggested very recently. A French group published this article in the Intensive Care Medicine Journal. And as you can see here, you start with analgesia, this first minimal sedation strategy, boluses of opioids, and then you can give what they call it multimodal analgesia, which is overlap between the opioids and non-opioids, things like ketamine, for example. The evidence about that is not strong. And then you go for the mild sedation, -1 process score. If you have good control, achieve the good control, well and good, you leave that on the mild sedation. If not, you go for the moderate sedation, -2 to -3, and then deep sedation if you still need to control ventilation. And then, as we said, we review the need for sedation twice daily. And with this comes the assessment for delirium. And we consider on daily basis whether we should interrupt sedation completely. And by interrupting sedation, there is good evidence that daily interruption of sedation leads to less days on mechanical ventilation and less days in the ICU. Excuse me. So less days of mechanical ventilation and less days on the ICU. So we talked about neuromuscular blocker. We talked about lung protective ventilation without neuromuscular blocker. What about COVID-19? This is one of the extreme situations that we faced over the last 9 months now. Been very challenging to everyone. And I'm sure that everyone experienced the same situation where you have to change your normal practice during the COVID-19. At this stage, I'll ask you again to make sure that you are doing the questionnaire, completing the questionnaire, because one of the questions about COVID-19 in the questionnaire, whether you have changed your practice during the pandemic or not. First of all, we have drug shortage during the pandemic. So the first thing we were told that, well, the national storage of propofol will not be enough. And then the propofol should be allocated, depends on priority centrally, depends on the priority of the hospital. So MRI, Manchester Royal Infirmary, got loads of propofol, 1%, while other hospitals didn't get the same amount of propofol. Fentanyl, alfentanil, remifentanil. So all this group, we had shortage of them, and we have to go back to the extreme old practice of using morphine, which was very annoying. We'll come back to the morphine in a minute and see why morphine is annoying for ventilation of ARDS or ventilation of anyone at all. It used to be used in the past, but it's not a modern practice anymore. But because of drug shortage, we have to use different types of sedation and analgesia, like morphine. We have to go back to midazolam again. What we've seen also with the COVID-19 is that they stay with the ventilation on the ventilator for a long time. They require more days on ventilation, whether that's because of the severity of the disease or because of the frequency of the VAB, ventilator-associated pneumonia. So because of this happening, many times we ended up having more days on ventilation, and eventually we get more sedation for longer time, and that means more consumption of the sedatives and analgesics. So again, that affected our practice, not only on the analgesic sedation, but also on the neuromuscular blockers. So sometimes we use rocuronium, and sometimes we get the pharmacist to ask us to use atra or cisatracurium. It depends on what drug is available at the time. And it was national, and I would say international shortage of the drugs as well. Another consideration in the COVID-19 is using what we called it satellite ICU. So for example, in my hospital, Manchester Royal Infirmary, we have 50 critical care, adult critical care beds, but we require to provide 200. So to quadruple the number of ICU beds, we have to extend to every single place in the hospital where oxygenation can be provided safely and ventilation can be provided in the same time, ventilation monitoring. One of these satellite ICU was theaters and theater recovery. So when you go to theaters, you're actually using the theater itself, the operating room itself, as an ICU, and we accommodated 2 patients in every theater, in every operating theater. And that meant that the patient will not be ventilated on our conventional type of ventilator, not the Burton Bennett or the Draeger ventilator or Philips or GE. They were ventilated on anesthetic machines. And being ventilated on anesthetic machines give you the advantage of having the volatile sevoflurane mainly that we use. So again, with the shortage of the propofol, we started, if the patient is already in theaters, we can use the volatiles. However, and I'm sure that my colleagues agree with me, if you are intensivist, you're not necessarily familiar with the use of volatile and the gas flow and the fresh gas flow and the flow rate. So these are technical issues. The end-tidal gas flow concentration and the MAC. There are certain things that require training and using anesthetic machines, and that will affect your decision whether you should be using volatile agents or not. So volatiles came especially when we use the satellite units, and also we use enteral additives. So for example, if the patient is requiring morphine, we add enteral morphine, especially when the patient is absorbing the feed. We don't have any problem with gastric residual volume or high aspirate. So in this case, we can go for adding oxynorm or morphine or morph, or even the long-acting morphine MST. So that will provide some enteral cover, lorazepam, sometimes clonidine. So other alternatives that can be given enterally while we provide IV sedation at the same time. Now, so the question always comes as how to avoid excessive sedation. What's enough and what's more than enough, and how to avoid excessive sedation. So, as mentioned, first of all, administration strategies. So, use of algorithm. There is no scientific evidence for sedation and analgesia. Most of sedation and analgesia protocols doesn't have any scientific or evidence-based background. But use of algorithm, and one of the things suggested to make sure that you are all the time reviewing your practice and keeping it within limits. So you don't give excessive sedation as long as the patient is achieving your RUS target. And the daily interruption of sedation, that's again, avoid accumulation of the sedatives by doing daily interruption. You make sure that you don't actually stop the sedatives and restart them in a certain time, as in a specific time, but you actually stop sedation until the patient is awake. So by doing this, you, to some extent, you assure yourself that the drugs are metabolized and not being accumulated in the patient. So by doing daily interruptions, you can avoid excessive accumulation. Intermittent bolus is another alternative. So let's say the patient is sedated already on opioids and propofol, and you need to deepen the sedation. And instead of continuous infusion of a third agent, you can just give the bolus of midazolam or lorazepam. Give something that will achieve control for a couple of hours and then reassess again. If you need again, you can repeat that boluses again rather than giving continuous infusion. And as we mentioned before, the nurse-led protocol, and eventually the choice of sedatives. And we'll talk about the choice of sedative in itself, but usually you will be trying to choose the short onset, short offset, and the least actively the least active metabolite producing sedative, so something that doesn't metabolite into another active sedation. There is also symptom-oriented strategy in avoiding excessive sedation, which is, as we said, analgesia first. Make sure that the patient is deeply or adequately analgesed, and the multimodal approach. And again, whether you use the paracetamol to add extra analgesia or non-opioid analgesia like ketamine or any other analgesics that you can use. So try to increase the number, but limit the dose of every single agent that you're using. And finally, one of the reasons to avoid one of the routes to avoid excessive sedation is to use non-pharmacological interventions. For example, if overnight the patient is asleep, minimize the interruptions, minimize any intervention. If you have to change the central line, don't do it overnight, do it in the morning. So keep the patient on lighter sedation during the night, give him enough sleep. And in the daytime, you can change the central line, and unless it's necessary that you have to change it overnight, but minimize to as much as you can the interruptions during the night. We'll come to the choice of drugs, and this is the most common question: what drugs do you choose? And of course, there are many factors that will contribute to decision making. The first will be the patient factors. So the patient age. Elderly patients will have slower metabolism. They are more likely to accumulate drugs. Most probably, they have other comorbidities as well. So you need to understand the side effect of each drug and which drug accumulate in liver failure, in renal failure, in acute kidney injury, or in renal impairment. The morphines and opioids will accumulate. Morphine will be accumulating more. In liver failure, the midazolam and benzodiazepines will be accumulating more. So you need to understand what sort of comorbidities the patient have or what organ failures the patient is suffering from, and then you can tailor your choice of the drugs. Other factors will include the drug kinetics and dynamics and the side effects of each drug and how to correlate them to the current patient situation or current patient status. And as we said, organizational factors will have an impact on your decision, which is which drug is available for you, which drug you're familiar with, and the cost of these drugs on the longer term. So if we take some of the commonly used drugs and opioids as a first line, usually will be the fentanyl or alfentanil. Remifentanil is a quick one. It's very short acting and can be quickly stopped. And then within minutes, you can assess the degree of wakefulness of the patient. Morphine is a second line, and it, as I said, it fell out of favor now. So we don't use it routinely in our practice, but we recently started to use it when we had shortage of fentanyl, alfentanil. We don't use it anymore in the COVID-19 now. And you can add some non-opioids as well. Talking about sedation, propofol is a common sedative. I think it's, again, this is the first line agent, and it works on GABA receptors. Midazolam is another GABA receptor, and both of them are used. Propofol is quicker onset and offset, while midazolam can accumulate. Dexdor or dexmedetomidine is an alpha-2 agonist, and it is safe drug when used within the therapeutic range, 1.5 microgram per kilogram per hour. But it does have some cardiovascular side effects, mainly hypotensive and bradycardia. So you need to make sure that the side effects are limited when using dexmedetomidine. And we can also use the volatiles. And finally, the neuromuscular blockers I'm not going to talk about because this has been discussed before. So with each of these drugs, you need to be aware of the side effects. Personally, having used the Dexdor as a sedative agent, it's commonly used as a weaning plan. So when we have a patient who's already on fentanyl and propofol, and we want to wake them up, commonly that we see that they become very agitated and then distressed by having the endotracheal tube. So instead of going back on sedation, we introduce Dexdor, dexmedetomidine, and then that will be a third agent. And then we stop the propofol, stop alfentanil or fentanyl, stop the opioids, and that will leave us with single agent when the patient is able to breathe. It doesn't have any effect on the respiratory center, so it doesn't suppress the respiratory drive, and the patient can wake nicely and fully, being communicating without the side effects of the morphine or the opioids and the propofol. And finally, we will come to special considerations during sedation and analgesia. In prone ventilation, of course, prone ventilation is tricky because you have to, it is effort consuming intervention. You need a lot of support from nursing staff and care and organization to turn the patient to the front and back to supine. And during turning the patient, you may need some neuromuscular blocker. But also when the patient is prone, you may need to use neuromuscular blocker to minimize coughing and the risk of barotrauma while the patient is prone. Again, there is no evidence that you need certainly neuromuscular blocker during prone ventilation, but it is one of the considerations that you can keep in mind. And if you're going to use that, you most probably you'll need deep sedation while the patient is prone. On the other hand, if you're using APRV for some of our patients, whether that's ARDS or COVID-19, you actually need to stop neuromuscular blocker and you need to wake them up and make them light. And the sedation will be to the minimal to keep them tube tolerant and at the same time able to breathe spontaneously. ECMO patients, if they still on the ECMO machine, the risk of displacement of the catheter is high, and this can be fatal. This can be disastrous if they are light or moving. So for this reason, most probably they will need deeper sedation. While you can use light sedation for patients on ECMO, if you think about extubating them while still in the ECMO machine. Again, this is one of the strategies that some of the centers followed to extubate while they're still requiring ECMO. And finally, we need to make sure that the drug metabolism, which is affected during ECMO, drug metabolism is affected during ECMO, so you need to make sure that you're giving adequate level of drugs while the patient is in ECMO. Weaning of sedation, and that will be our last bit. Commonly, when you start weaning the sedation, that you'll get a withdrawal syndrome, and we've seen this very recently. The longer they stay in the ventilator, the most common they will have withdrawal syndromes later on, and it's a mix of psychological, psychosomatic, and autonomic syndrome, where you can get something similar to the CERS response, and we commonly confused ourselves as the patient becoming septic, tachycardic, and sweating and fever, and whether that was sepsis or actually that was withdrawal from the sedatives. The difference that they, with the withdrawal syndrome, commonly you get hypertension rather than hypotension. Delirium and agitation can be commonly encountered during weaning of sedation. And that's why we start thinking about, okay, so maybe first of all, the rate of withdrawal of sedation shouldn't be abrupt or quick. Someone has been on midazolam or propofol for 3 weeks or 4 weeks. You cannot suddenly say, do sedation hold and stop immediately now, but maybe becoming more gentle on weaning the sedatives. So the rate of reducing the sedative would be less or slower. Also, as I said, you can think about alternative routes or drugs. If the patient is having Dexdor, you may think about giving clonidine enteral, clonidine tablets. If the patient is already on opioids, you may think about giving morphine MST or giving some oxynorm. So other routes or other alternatives to facilitate the weaning of the sedatives. The use of antipsychotics, mirtazapine or olanzapine or quetiapine, may be helpful in reducing the delirium while the patient is being weaned off the sedation. And finally, it's the non-pharmacological interventions that we mentioned before, how to wean the sedation and at the same time minimize the interruption of sleep, make the room quiet during the night, turn off the light, minimize the noise, minimize the clinical interventions during the night, restore the sleep wakefulness cycle, and these things can minimize the agitation and delirium that accompanies the weaning of sedation. So my take-home message for you will be, think about analgesia first approach, targeted sedation. If you can use some protocols, that will be great. Daily interruption of sedation and avoid delirium, avoid non-necessary clinical interventions. Most of this presentation is published in the analgesia and sedation patients. So this is very recent article in 2020, November, so a couple of months ago, as by French group about analgesia and sedation in patients with ARDS. It's free access, so hopefully you'll find more information if you're asking for more details about analgesia and sedation in patients. I hope that you have answered the questionnaire, and thank you very much. I'm ready for any questions.
Thank you, Dr. Shams. Very informative and comprehensive updated review. Thank you very much. And I have some questions here. One is asking, you mentioned that morphine is not good choice in mechanically ventilated patients, either ARDS or not. Why?
So morphine used to be common choice in the past, but because of the side effects and because of the prolonged effect and the AKI is commonly present in the ICU, it started to fall out of favor, and now we're using something that is more short acting, short onset and short offset, and they started to move now to the fentanyl, alfentanyl or remifentanil group as a first choice now.
Perfect.
It's not excluded completely, but it's not my first choice.
Yeah, perfect. Another question, neuromuscular blocker, as it decrease the mortality in ARDS? I think that's been answered already by Dr. Adel Hussein in a whole lecture. You can just go through it. So just for the sake of time, another question, what do you think about sedation during NIV and COPD patients? What is your choices?
It's interesting. So recently, in using NIV or nasal high flow in the context of COVID-19, we now started to prescribe some morphine, not morphine, but diamorphine or fentanyl patch actually, which is giving. It's mainly to relieve anxiety rather than sedation. So yes, it is used. And for other patients, the use of small dose of ketamine, just a tiny dose of ketamine. I can't remember exactly the dose. I don't commonly use it, but I remember that there is a study for the use of ketamine for patients on an IV, just to relieve the anxiety and the stress rather than complete sedation.
Yeah.
Dexdor is another option.
Yeah, Dexdor is a good option. Thank you, Dr. Shams.
Thank you very much.
Another question I am not quite sure is regarding ARDS with pregnant women, especially with the first trimester. Any special recommendations and your personal experience? Of course, not about the whole ARDS topic, but only analgesia sedation, I believe.
It's not different from any other sedation. Propofol, midazolam, and all other sedatives are safe to use, as in all other allergies are safe to use. There is a risk to the baby, but if you reach the ARDS stage in pregnant woman, it will be the risk between keeping the mother alive or keeping the baby alive.
Perfect. Thank you very much, Dr. Shams.